Hi, this is Patrick Monahan, and I'm going to present a case here of 27 gauge floater-only vitrectomies. I'll explain to you exactly what that is in a minute, but first let me show you how it starts. 3 ports are placed into the eye, and the key on this is that they are 27 gauge, which is quite fine and easily goes in and out of the eye without having to do any suturing after we're done. It's also less chance of causing leakage. You can see here we're measuring, we're putting in the first port, the second port's in, now the third port's in. I didn't show you all the gruesomeness of that. The light pipe goes into one port. You saw the infusion cannula go into the first port, which means we pump fluid into the eye. They're putting a little goniosol on the top here, and then I'm going to put a little lens on so we can see inside the eye as we work. The vitrector or cutter, which is the third instrument, will go through in the third port, and that actually it has a sucking, it suctions out the vitreous floaters, and at the same time it cuts. It has a little guillotine cutter at the end that sucks in and cuts, so it doesn't pull on the jelly. You don't want to pull on the jelly because you don't want to pull the jelly off the retina. You don't want to cause a retinal tear or break. So the cutter is running right now. It's at the very tip, and you can see the jelly moving around the tip. The eye is not hollow, it's full of this clear jelly, but the jelly has a lot of little fibers that run through it, and we're pretty far down in the bottom of the eye. Now you can see some of those fibers, and you can see the jelly moving around in this patient. In a minute here you'll see a lot of little tiny fine white dots. They're actually clumps of the vitreous, which is what the patient's really complaining of. As you look behind the cutter, you can see this darker spot. That's actually the fovea, or the center of the macula, right on the back of the retina. Now you can see some of those little spots coming in. You can see as we backlight those, and you'll see some more right there. Those little spots often cause shadowing on the back, especially since they're stuck right in the center of the visual axis. They cause some real trouble, always being right in the way of what the person's trying to see, or floating in and out of the way. So we get those out of the way, first, going through the center, and then we slowly work our way around the vitreous internally and continue to clean out the central cavity. What we're purposely doing here is we're leaving the vitreous on the back, on the retina itself. You can see the optic nerve now coming into view. The optic nerve is just to the side of the macula. And there's your fovea, which is your dark spot in the middle. That's the other side of the macula there. The whole retina continues to go all the way out, lining the inside of the eye. So we're going to work our way around and clean the vitreous as much as possible. We've already got the center part cleaned out, which is the majority of what we want to do. But it's very important to make sure we don't leave anything, and also I want to check at the end to make sure that we don't have any breaks or tears and that everything's going well. So we'll go around a few times here. The reason we end up doing this procedure is usually for younger people who are myopic. They develop an odd type of floater, which is the ones you were just seeing, the little cotton ball type things, and oftentimes if those are left, this is a younger patient, but if those are left, they become much larger and more problematic. These patients do not have a posterior vitreous detachment, which means that the jelly has not come off the back of the off the back of the eye, off the retina itself, which will happen later in life. This doesn't prevent that from happening by doing this procedure. But when that happens, that's when you're at risk for retinal tears or detachments, because as your jelly peels off your retina, it can pull and tear it. So we're just trying to make sure that doesn't happen here. The biggest problem, of course, with these floaters is it's hard to clean them out without causing cataract in the older procedures we used to do, which was larger gauge vitrectors, as well as the fact that when you clean the jelly completely off the retina, which is the way it used to be done, the oxygen would go from the retina up to the lens, and that's actually what causes cataracts by oxidating the lens. What we're doing is we're leaving that jelly on the back, on the retina, and leaving some jelly on the back of the lens, and just cleaning out the cavity in the center. That hopefully and theoretically prevents cataract from forming at any time than it would normally form anyway. Now you can see we've taken off the little lens on the top. We're going to go to what we call a wide field lens. This is very important. This is to check the peripheral retina around the edges. You're going to see that all your structures now are going to be much smaller, but we're going to have a much wider field so that we can see around the edges and make sure that there's no retinal breaks or tears. And that the rest of the retina is in good shape. There's no weak areas, especially for nearsighted folks who oftentimes end up with something called lattice degeneration, or a thin or weakening of the retina at the edges. So at this point, I'm really looking at my instruments, and I can see a little bit of vitreous still coming in, and we're cleaning around the edges. But you're going to see we kind of go around, and we actually do this 3 or 4 times. I've cut the video here a little just to shorten the time. But there's, you can see the nerve, the macula with the fovea in the middle, and we kind of went all the way around there, and we would have done that a couple more times. But there are no retinal breaks or thinning here. Now, the removing of the ports at the end is quite simple. These ports all self-seal, but we just grab those, pull them out, and use a Q-tip to push over. These come out very nicely. They leave very small micro holes which self-close. Usually the holes themselves completely close within 48 hours or so. We often will put a patch and shield on someone after the surgery for 2 or 3 days, because the biggest problem or complication you can get is that they develop low pressure in the first couple days because of the holes, and then that seals up.